Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Dear colleagues in PGs, nowadays we are discussing the hepatitis B in an interactive workshop form. In the last video, we found or we discussed the aim of this workshop, the objectives of these workshops, goals of this workshop, and we discussed the Z model of the chronic hepatitis B. The first phase is the HBe antigen positive infection. Then comes the HBe antigen positive hepatitis. And the third stage is HBe antigen negative infection. And then it comes the HBe antigen negative hepatitis. Today, we shall proceed further and we shall see the HBV life cycle and its clinical implications to understand that how this is important and how it helps us in treating these patients with antiviral therapies. So today we shall discuss the HBV life cycles and its clinical implications. We all know the hepatitis B virion has got surface, and this is the base surface antigen, which has got the three main proteins, the small proteins, these the orange ones, the middle size proteins, the orange and the green ones, and the large proteins, which are the orange, blue, green, and the blue ones. And of course, these are the domains, the HBs antigen domains, pre-S, the pre-S1, pre-S2, and the S. And then there is the envelope, which is the E antigen. And inside that is the core, which consists of the relaxed circular HBV DNA and the DNA polymerase, and of course, the nucleocapsid are the core antigen. So if we see this, there is the HBs surface antigen, and then there is the HBe antigen, and then the HB core antigen, the DNA, and the DNA polymerase. So what the hepatitis B virons brings into the body is the HBs antigen, HBe antigen, the core antigen, and the DNA. And what the body responds immunologically, it makes antibodies against HBs antigen, the anti-HBs, and antibodies against the E antigen, anti-HBe, and the antigens against the core antigen, anti-HBC, IgM, and the total, and of course DNA. There's clinically, these are, we are able to detect these. We haven't been able to detect this in our clinical practice, the core antigen. This is the life cycle of hepatitis B. This is the hepatocytes, and this is the nucleus. The hepatitis B virus, when it reaches the hepatocytes, there is entry. What it does, that it leaves the surface antigen outside and the nucleocapsid, it enters the cytoplasm. Then it traverses the cytoplasm, enters into the nucleosides. There the relaxed covalent DNA is converted into covalently closed circular DNA, cccDNA, and then there is transcription into messenger RNAs. 4 templates are formed within the nucleus, and this is the how the relaxed circular DNA, rcDNA, it is converted into covalently closed circular DNA or cccDNA. There are 4 steps involved in it, and first is the removal of the polymerase and of the recurrent sequences. Second is the removal of the RNA primer. Third is the completion of the viral positive DNA strain. Fourth is the ligations of the DNA extremities, and 5 is the association of the cellular proteins. If you don't remember these, no issue, but you should remember that the relaxed circular DNA is converted into cccDNA within the nucleosides. So the 4 templates, one is the translation into the HBs antigen, another is the translation into the capsid HBe antigen, and then there is incapacitation of this capsid E antigen. And what is this? There are 2 reactions. One is the reverse transcription, that is the cDNA minus strands from the pre-genomic DNA, and then there is synthesis of the positive DNA from the negative DNA, and then after this incapacitation, the nucleocapsid is formed, and then these are released outside, and the surface antigen, it covers the nucleocapsid, and a mature hepatitis B virion is formed. The role of HBV replication, rate of HBV replication depends upon immunological response. If the immunity has controlled the proliferation will not happen. But if it is allowing the proliferation, it will proliferate and it will infect the surrounding hepatocytes. The innate immunity is in the form of the NK cells, natural killer cells, and other cells, while adaptive immunity is in the forms of the B cells and the T cells, and the T cells forms the CD4 plus T cells and CD8 plus T cells. This is very, very important, and you should remember the natural course of the hepatitis B. When hepatitis B happens as acute hepatitis B, it may be asymptomatic or symptomatic. If this is symptomatic, it can get two courses. One is that the patient recovers and the HBs antigen is lost, or another option is that it enters the chronic hepatitis B phase, that is the HBs antigen positive chronic hepatitis B phase. Or it may be asymptomatic. The patient may not have noticed that I am having acute hepatitis B, and after 6 months, the patient has entered into the chronic hepatitis B phase, that is the HBs antigen positive phase. Here, typically, it undergoes 4 stages. The first 2 stages, it is HBe antigen positive chronic hepatitis B phases or stages, and the last 2 are the HBe antigen negative chronic hepatitis B phases. The first is called chronic hepatitis B immune tolerant phase, and then it is called chronic hepatitis B immune reactive phase. The third is chronic hepatitis B immune control phase, and the fourth is chronic hepatitis B immune escape phase. And then the fifth is the occult hepatitis B, when there is no surface antigen but still core antibodies is there and cccDNA is there. Remember that these phases, these are interchangeable. The patient may move from immune tolerant phase to immune reactive phase or backwards. Similarly, immune reactive phase to immune control phase are backwards. Similarly, immune control phase to immune escape phase are backwards. And similarly here to occult hepatitis B are backwards. This is very, very important that you should remember this concept. Nowadays, the new terminology is that the immune tolerant phase and immune control phase is called infection phase, and the immune reactive phase and immune escape phase is called the hepatitis phases. This is the HBV serological patterns of acute hepatitis B virus with recovery. Typical serological course: patient is symptomatic. Initially, this is the time duration. First is HBe antigen positivity phase, then anti-HBe positive phase. This is the HBs antigen which appears and then disappears within 6 months. And this is the IgM core antibodies which comes and then disappears. And this is the anti-HBs. When the HBs antigen disappears, the anti-HBs appears. And this is the anti-HBc core antibodies. Remember, in this, it may be the 8 weeks duration of 24 weeks to 32 weeks, when there is no HBs antigen and there is no anti-HBs, but the patient has acute hepatitis B, or the patient had acute hepatitis B. This is called a window period where the IgM core antibodies will tell you that the patient has got acute hepatitis B. On comparison, the progression to chronic hepatitis B virus infection, typical serological course within 6 months is acute, after 6 months is years. The HBe antigen positivity extends beyond 6 months, and later on there's anti-HBe positivity. The HBe surface antigen, it stays there for years. Similarly, the HB core antibodies, it stays there, and the IgM antibodies then comes and goes, but there is no emergence of the HBs antibodies. These are the serological patterns in short, and it is important that you are aware of it. We shall discuss the HBV serological patterns and details in another dedicated video. But here you can just imagine that the patients, either the infection is present or infection is not present. If the infection is present, it may be acute or it may be chronic in acute. This is a serological pattern: HBs antigen positive, anti-HBs negative, E antigen positive, E antibody negative, total core antibodies positive, IgM positive, DNA positive, and the ALT very, very high. The chronic hepatitis B phase, we know it has got 4 phases: immune tolerant, reactive, escape, control, and escape. In immune tolerant phase, again, HBs antigen positive, anti-HBs negative, E antigen positive, E antibody negative, core antibodies positive, IgM negative, PCR positive, and DNA level, the ALT level normal. While immune reactive phase, the same: HBs positive, anti-HBs negative, E antigen positive, E antibody negative, core antibodies positive, IgM negative. The PCR is raised, but not as raised as it is in the immune tolerant phase, and ALT is raised here. In the immune control phase, again, S antigen positive, anti-HBs negative. Now the E antigen is negative, and reverse, that is the antibodies positive, core antibodies positive again, and the PCR load is at its minimal, and ALT is normal. In immune escape phase, again the HBs antigen positive, E antigen is HBs antigen antibody is negative, E antigen positive, E antibody negative. The total core antibodies positive, IgM core antibodies negative, and the DNA level is positive but less than the immune reactive or immune tolerant phase, but higher than the immune escape phase. ALT is raised again. Then there may be the patient has got immunity, or patient has become immunized. It may be because of the past infection or because of the vaccine. In the past infection, the HBs antigen will be negative, anti-HBs will be positive, the E antigen will be negative, and E antibody will be positive, total core antibodies will be positive, IgM antibodies will be negative, PCR negative, and ALT normal. This is very tricky, that if the patient is immunized because of the vaccine, again, the surface antigen will be positive, rest everything will be negative, and ALT will be normal. So 4 phases comes in our patients, as I already told you, and this is the E antigen positive hepatitis phase and E antigen negative hepatitis phase, when there is inflammation, necrosis, and fibrosis, and because of this, the liver fibrotic contents, it increases from F0 to F1, F2, and F3, and F4. When there is no fibrosis, this is called liver without fibrosis. When the patient has got F1, F2, F3 fibrosis, that is the mild, intermediate, and advanced fibrosis, it's a fibrotic liver disease. And when it is F4 fibrosis, this is called cirrhosis. So, dear colleagues, today we discussed the HBV life cycle and its clinical importance. And this is important. If we apply this knowledge, we can categorize our patient, whether our patient needs treatment or doesn't need treatment, and what is the risk of hepatitis B-related liver cirrhosis and its complications. So, with applying our basics knowledge and categorizing the patients into different 4 categories, we can start the treatment, or we can wait, and we can defer the treatment for that very time. In the next video, we shall discuss what should be the workup before starting patient on treatment, and if a patient presents to us with HBs antigen positive, what workup we should do, and what is the role of HBe antigen in the management of chronic hepatitis B. Till then, take care. Goodbye.